1, 2,
and review 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Imagine you're standing next to a hospital bed.
Right.
Your patient, who is, sitting up and talking to you about their grandchildren just 5 minutes ago, is suddenly looking right through you.
No, that's always a terrible feeling.
It really is. I mean, they are confused. Their speech is just a little slurred. And as you lean in, you notice that one of their pupils has just blown up to the size of a dime.
Yeah, that's the nightmare scenario.
Exactly. In that specific moment, you have mere seconds to realize that their brain is actively being crushed from the inside. The human brain might be a sealed black box, but today we are learning exactly how to read those terrifying external warning signs before it's too late.
It is the ultimate high-stakes environment. I mean, today's deep dive is taking a highly specialized tactical approach to the nervous system. We are analyzing foundational neuroanatomy, assessment, and diagnostics.
Yeah.
But we're doing it specifically through the lens of an elite ICU intensivist and, a critical care nursing instructor.
Yeah. Okay, let's unpack this. The mission for you listening today is simple, though it is far from easy. We are aggressively applying the Pareto principle.
The 80-20 rule.
Right, the 80-20 rule to this incredibly dense material. We are going to extract the absolute highest yield facts. I mean, we aren't just memorizing textbook definitions here.
No, absolutely.
We are looking for the precise nuggets of knowledge you need for deep clinical understanding, for acing those brutal board exams, and most importantly, for making those split-second life or death decisions at the bedside.
If we connect this to the bigger picture, we are going to draw a direct line between microscopic, invisible cellular anatomy, right, and the macroscopic, life-threatening changes you see standing right next to a patient's bed.
It's so vital.
It really is. And we should set the context for our timeline here. Today is August 12, 2026.
Good point.
That timestamp matters. Because while anatomy textbooks give you the static foundation, the standard of current critical care knowledge is entirely about dynamic application. It's about how you deploy that knowledge in real time, under immense pressure. That is what actually saves lives.
Absolutely. So we are starting with intracranial dynamics and the absolute terror that is brain herniation.
Terror is the right word.
To give you a mental image of what we are dealing with, I want you to think of the human skull like a heavy-duty bank safe.
Okay, I like that.
It's an evolutionary marvel.
Yeah.
Perfectly designed to protect the incredibly valuable, fragile, gelatinous contents inside from external trauma.
Yeah, it does a great job at that.
It does. But here is the fatal flaw in that design. If pressure builds up inside that safe, say, from a fast-growing tumor, swelling tissue, or like a pooling hemorrhage, the safe cannot expand. It is totally unforgivingly rigid.
Totally rigid.
And the only way out of that safe is through the tiny drain hole at the very bottom, which in the skull is called the foramen magnum.
That analogy perfectly captures the 80-20 core of intracranial dynamics. I mean, the brain is enclosed in this rigid box, and it's wrapped in three protective meningeal layers.
Right, the meninges.
Yeah, you have the thick, leathery outer layer called the doromater. Beneath that is the web-like arachnoid layer. And then the highly vascular inner layer hugging the brain tissue called the pia mater. But inside this safe, you also have rigid folds of that doromater, like the falx cerebri, which separates the left and right hemispheres.
Right.
And the tentorium cerebelli, which acts like a shelf separating the upper brain from the lower brainstem. These structures are meant to stabilize the brain, but they also severely restrict tissue movement.
Right. They become these hard, sharp edges that soft tissue can get pushed against.
Exactly. And the must-know concept here is the Monroe-Kelly doctrine. Even if we just think of it conceptually, it dictates everything. Inside that rigid skull, you have three things.
Just three.
Just three.
Yeah.
Brain tissue, about 150 milliliters of cerebrospinal fluid, or CSF, and the blood supply.
Yeah.
They all have to share this rigidly fixed space.
So if one of those three things increases in volume, or if a completely new, unwelcome mass like a tumor is introduced, something has to give.
It's pure physics.
Exactly. Let's trace the pathophysiology of this step by step, because understanding the mechanism is everything. The trigger is that expanding mass. The immediate physiologic change is that the pressure increases against the rigid walls of the skull and those tight dural folds.
Yes. And initially, the body tries to compensate. It's smart, you know.
Yeah, it tries its best.
It might increase the absorption of CSF back into the bloodstream, or it might alter the production of CSF to make a little more room. It might even shunt some venous blood out of the skull.
But that only works for so long.
Right. This compensation has strict limits. When those limits are breached, you enter the decompensation phase. The pressure has nowhere to go but down.
Down towards that drain hole.
Exactly. It forces the soft brain tissue downward. This is central herniation, where the brain and the brainstem are physically pushed down through that drain hole, the foramen magnum.
And the classic clinical finding that screams this is happening right in front of you, it's the compression of cranial nerves III at the tentorial notch, which causes that sudden pupillary dilation we talked about in the hook. But I need you to explain the mechanism here. I mean, why is cranial nerve III the canary in the coal mine?
What's fascinating here is the precise anatomical pathway of cranial nerve III, the oculomotor nerve. It exits at the very top of the brainstem, right at the edge of that rigid dural shelf we mentioned, the tentorial notch.
Okay.
So when an expanding mass pushes the upper brain downward, this delicate nerve is perfectly positioned to get crushed between the brain tissue and that hard dural edge.
Ouch.
Yeah. Now, functionally, cranial nerve III carries parasympathetic fibers that tell the pupil to constrict.
Ah, the rest and digest signals.
Exactly. And a crucial anatomical detail is that these parasympathetic fibers ride on the very outside of the nerve bundle.
Oh, wow. Really?
Yeah, on the outside. So when the nerve gets compressed, those outer fibers are the very first to be pinched off. The parasympathetic signal to constrict is blocked.
Leaving the sympathetic system in charge.
Exactly. Without it, the sympathetic nervous system's input, the fight-or-flight signal to dilate the pupil, is completely unopposed. It takes over entirely, causing the pupil to dilate widely and become completely unreactive to light.
That is such a vital mechanical explanation. It's not just a random symptom, it's a direct physical consequence of the brain being squeezed. So, moving to the assessment side, we know the blown pupil is a late, terrifying sign.
Very late.
But early on, before that happens, what are we seeing? The sources emphasize altered mental status, and there is a massive trap here for healthcare providers,
A
right?
huge trap, especially for novice nurses in the ICU. The trap is looking at an older patient who suddenly has acute cognitive changes. Maybe they are agitated, confused, or just lethargic, and writing it off as just aging or their baseline dementia.
Oh, yeah, that happens so often.
You have to use validated tools to assess this properly, like the confusion assessment method, or CAM, which is specifically designed to detect delirium.
Because delirium is different from dementia.
Fundamentally different. Delirium is an acute, sudden onset transient disorder. In a critical care setting, sudden delirium is frequently an early screaming indicator of hypoxia, metabolic derangement, or, in this context, subtly increasing intracranial pressure.
Right. You cannot ignore acute confusion.
Never. It's the brain's first cry for help.
And then you start seeing the classic findings of rising pressure, like papilledema. That's the choked disc swelling of the optic nerve head that a provider sees when they look into the back of the eye with an ophthalmoscope.
Right.
But the late, highly dangerous findings are anisocoria, which is unequal pupil size, and dysconjugate gaze, where the eyes are no longer tracking together. Now, in the ICU, nurses are constantly documenting pupil checks. I have a practical question about that.
Go for it.
What is the actual difference between writing parallel and parallel in a patient's chart?
It's a critical distinction. The A in parallel stands for accommodation. This is the pupil's ability to constrict and adjust when focusing on a near object.
Right.
To actually test accommodation, you have to ask the patient to actively focus on your finger or a penlight as you move it closer to their nose.
Right, they have to follow a command.
Exactly. If a patient is unconscious, comatose, or severely delirious, they simply cannot follow that command. Therefore, accommodation physically cannot be assessed.
That makes total sense.
In those cases, you must document parallel pupils equal, round, and reactive to light, and leave the A off. Documenting parallel on a comatose patient tells the intensivist that the nurse doesn't actually understand the assessment they are performing.
That is a great exam trap to watch out for. So if we see these signs, altered mental status progressing to unequal pupils, diagnostics have to happen at lightning speed. A CT scan of the head without contrast is the rapid choice for finding a fresh hemorrhage or a large mass.
Correct. While an MRI gives much better, highly detailed resolution of the brain tissue, it takes significantly longer.
And they have to lay still for it.
Right. It requires a stable patient who can lay flat for 45 minutes. In a life-threatening emergency where a patient is actively herniating, seconds count. The rapid CT scan is the gold standard for immediate triage.
Which brings us to how a nurse processes this using the ADPIE framework. Let's walk through it realistically. You walk into the room for your assessment. You notice the patient is harder to wake up than they were an hour ago. Their Glasgow Coma Scale is dropping. And you shine a light in their eyes and see that early cranial nerve third compression one pupil is sluggish.
Instantly, your nursing diagnosis is a severe risk for altered cerebral tissue perfusion. Your planning phase means your immediate goal is to maintain whatever neurologic baseline they have left and prevent that downward herniation.
Okay.
Implementation requires continuous, highly frequent neuromonitoring, particularly those PRL checks and GCS scoring. And evaluation is confirming that, hopefully through medical intervention, the pupils remain equal and reactive and their mentation stabilizes.
Breaking down the priority nursing actions, because sequence is everything here. First, you assess the level of consciousness and pupillary reaction. Next, you hold any sedatives that might be masking the neuro exam.
That is so important.
Right. You need to see exactly what the brain is doing naturally. Then you prepare the patient for that rapid CT scan.
Let's talk about medications in this context, specifically one you might not immediately associate with brain imaging, metformin.
Wait, the diabetes drug?
Yes. If that rapid CT scan requires iodine-based contrast to enhance the visualization of blood vessels or tumors, the nurse absolutely must hold the patient's metformin for the day of the test and usually 48 hours after.
Why? What's the mechanism there? I mean, it's just a CT scan.
Iodine contrast is notoriously nephrotoxic. It can be very hard on the kidneys.
Okay.
Metformin is cleared by the kidneys. If the contrast causes acute kidney injury, the metformin cannot be cleared. It builds up in the bloodstream and can cause a rare but highly fatal condition called lactic acidosis.
Oh, wow. That's a massive deal.
It is a vital nursing catch. You also have to encourage fluids, either IV or PO, to flush that contrast out of the kidneys as quickly as possible. Furthermore, we must carefully monitor any sedatives and hypnotics the patient is on, because toxicity from these drugs can actually cause nystagmus.
Involuntary eye movements.
Right, nystagmus and ataxia, which will completely confuse your neurologic assessment.
Okay, so that covers medications. Let's look at procedures. In the ICU, if pressure is rising, the neurosurgeon might place a ventriculostomy.
Also known as an EVD.
Right, which is a catheter drilled directly into the brain's ventricles to monitor CSF pressure directly and even drain it off to relieve pressure. But the sources highlight a massive flashing red warning light regarding another very common procedure, the lumbar puncture, or spinal tap.
Yes.
The text says it is strictly contraindicated if there is increased intracranial pressure. Why is it so deadly in this scenario?
Think back to your bank safe analogy. You have massive high pressure building up inside the skull. Now, the spinal canal is directly connected to that intracranial space. It's a closed fluid system.
Okay, I'm following.
If you puncture the lumbar spine at the bottom of the back and remove fluid, you suddenly create a localized low-pressure sink below the brain.
Oh, wow.
Physics immediately takes over. Fluids move from high pressure to low pressure. That massive high pressure up at the skull forcefully pushes the brain tissue down toward that newly created low pressure sink in the spine.
So it pulls it down.
By doing the lumbar puncture, you actively cause the exact downward central herniation you are trying to prevent. It pulls the brainstem right through the foramen magnum. It is a fatal move.
That is terrifying, and it illustrates exactly why you have to understand the mechanics, not just memorize a rule like no LPs with high ICP. Let's look at the hemodynamic and respiratory implications of all this.
Absolutely.
The brainstem, specifically the medulla, contains the vital autonomic centers for respiratory drive and vasomotor function, meaning heart rate and blood pressure control. When herniation physically crushes those centers, you get immediate respiratory arrest and hemodynamic collapse.
And fueling all of this is the cerebral circulation. You've got the internal carotid arteries feeding the anterior or front of the brain, and the vertebral arteries feeding the posterior or back.
Right.
They meet in a highly vascular loop at the base of the brain called the circle of Willis.
Which acts like a traffic roundabout, right? If one road is blocked, blood can flow the other way around to still supply the brain. But there's a fun fact from the text here. The formation of the circle of Willis varies wildly among the population, and imaging shows many people have a completely incomplete formation.
It's true. which means if one of those main arteries gets blocked by a clot, they don't have that built-in anatomical detour system, making them vastly more susceptible to catastrophic, irreversible strokes compared to someone with a fully intact circle.
That's crazy to think about.
It is. Now, regarding fluids and electrolytes in the brain space, cerebrospinal fluid is produced in the choroid plexuses within the brain's ventricles at a rate of about 500 milliliters a day. And normal CSF is highly specific.
Right, the lab values for CSF are critical. It should have a glucose level of 40 to 70 milligrams per deciliter, a specific gravity of 1.007, and it must contain absolutely zero red blood cells. Why the glucose?
The brain has no capacity to store energy, none. It relies entirely on a constant, uninterrupted supply of oxygen and glucose from the blood and CSF to survive.
Okay.
If that CSF glucose level drops significantly below 40, it's a major red flag for a bacterial infection, like meningitis, because the bacteria are literally eating the glucose in the fluid.
Wow, and the zero red blood cells rule.
Blood is highly irritating and toxic to raw brain tissue. If you see RBCs in the CSF, you have a subarachnoid hemorrhage until proven otherwise.
Okay, let's tie this together with complications using the intensivist framework.
Yeah.
Cause, an expanding mass.
Finding, right.
Unilateral dilated pupil. Nursing action. Immediate escalation to the provider and preparing for emergency intervention.
Exactly. But how do we know the patient is deteriorating before the pupil blows? The text gives us highly specific signs. The patient is getting worse if they develop stupor, if they become mute, or if they develop a new downward drift with palm pronation during a motor exam.
Wait, hold on. I get the downward drift, that's weakness. You have them hold their arms out, eyes closed, and one arm starts to sink.
Right?
But why palm pronation? Why does the hand turn inward? How does that specific movement mean their brain is swelling?
It's an incredibly sensitive, elegant neurological test. Think about the musculature of your forearm, the muscles that supinate the forearm. The ones that keep your palms facing up toward the ceiling are naturally slightly weaker than the pronator muscles, which turn the palms down.
Okay, I'm with you.
When you have an upper motor neuron lesion or increasing edema in the opposite cerebral hemisphere's motor cortex, it disrupts the signaling to that arm. The supinator muscles are the very first to lose their strength under that stress. Because they weaken first, the naturally stronger pronators overpower them, causing the hand to involuntarily turn inward. It reveals mild, subtle arm weakness before the patient even realizes they have it, long before the arm actually starts to drift down.
That is brilliant. It's subtle, but it tells you so much about what's happening in the cortex.
Yeah.
So when it comes to escalation, based on these assessments, if you see unilateral pupil dilation, that is absolutely not a monitor and chart situation.
No.
That is an immediate rapid response or code situation. You do not wait.
And for pattern recognition on exams and in practice, if you see nystagmus plus ataxia plus dysarthria, which is slurred, poorly articulated speech, you should immediately think cerebellar lesion. Or in a hospital setting, you must rule out sedative or alcohol toxicity as they mimic cerebellar strokes perfectly.
Let's summarize the intensivist thinking here. The problem is an expanding mass. The failing physiology is the exhausted CSF compensation leading to rapidly rising intracranial pressure. The immediate threat is central brainstem herniation and respiratory arrest. The intervention is securing the airway, getting a rapid CT scan, and prepping for neurosurgery. The reassessment is continuous, minute-by-minute pupillary and GCS checks.
So if our listeners take nothing else to their next shift regarding intracranial dynamics, they need to remember these core concepts. Number one, the core pathophysiology. The skull is a rigid box. An expanding mass has nowhere to go and will eventually compress cranial nerve III and crush the brainstem.
Number two, your key assessment findings are anisocoria, unequal pupils, and a positive pronator drift.
Number three, the most dangerous complication is downward central herniation through the foramen magnum.
Number four, your priority nursing action is establishing a rock-solid neurologic baseline so you can perform frequent mental status and PRL checks and detect subtle changes.
And number five, the most important treatment is a rapid CT scan to identify the mass, remembering to hold metformin if contrast is used.
The one-sentence clinical picture you need to burn into your brain. A patient with a sudden decline in consciousness and a unilateral dilated pupil is actively herniating. If you see a dilated pupil and a dropping GCS, think central herniation and do escalate immediately to save their life.
Excellent. Now let's transition from the rigid vault of the skull down into the body. While the brain is the ultimate command center, the The spinal cord is the superhighway that actually executes those commands and brings information back.
So what does this all mean when that highway gets blocked or when the pavement is torn up? Let's move into concept 2, motor pathways and spinal cord integrity. Specifically, we need to focus on deciphering the difference between upper motor neurons and lower motor neurons.
Applying our 80-20 overview to the spinal cord, motor control is essentially a two-relay system. It's remarkably simple in its architecture. You have upper motor neurons, or UMNs, which originate high up in the cerebral cortex of the brain and travel all the way down the spinal cord. Then you have lower motor neurons, or LMNs, which start in the anterior horn of the spinal cord's gray matter and go directly out to innervate the skeletal muscle. Being able to identify clinically which one of these neurons is damaged tells you exactly where the lesion is located.
Let's look at the pathophysiology of how this breaks down. The trigger is a spinal cord injury, a tumor, or peripheral nerve damage. The physiologic change is the physical interruption of the descending corticospinal tract for the UMNs or damage to the anterior horn cells for the LMNs.
Right.
Now, regarding compensation, it's a mixed bag. Schwann cells in the peripheral nervous system can attempt collateral sprouting and try to regenerate damaged nerves if the environment is right.
But regeneration in the central nervous system, the brain and spinal cord, is notoriously poor due to inhibitory factors.
Exactly. The decompensation is the complete loss of innervation to the muscle. And the clinical findings that result are spasticity versus flaccidity. Okay, here's where I need you to explain the why. This always trips people up. Why do upper motor neuron lesions cause spasticity and hyperreactive reflexes, while lower motor neuron lesions cause total flaccidity and dead reflexes?
It all comes down to understanding the reflex arc. Let's look at the simplest example, the knee-jerk or patellar reflex.
Right.
A provider taps your patellar tendon with a hammer.
Right. Classic doctor visit stuff.
Exactly. That physically stretches the quadriceps muscle. A sensory receptor in the muscle fires off, sending a signal via an afferent sensory neuron straight to the spinal cord. It goes into the cord, synapses directly with a lower motor neuron in the gray matter, and that lower motor neuron immediately sends an efferent signal right back to the quadriceps muscle, telling it to contract.
Pick the leg out.
Exactly. That entire loop sensor to cord back to muscle is the lower motor neuron circuit. It happens without the brain even knowing about it.
Okay, so where does the upper motor neuron come in?
The upper motor neurons are constantly sending descending signals from the brain down to these lower reflex arcs. And crucially, these descending signals are primarily inhibitory. They're basically the brain constantly whispering to the lower reflexes, calm down, don't overreact to every little stretch, keep it smooth.
Ah. So if you have an upper motor neuron lesion, like a stroke in the brain or a severed cervical spinal cord, you physically cut off that descending inhibitory signal?
Yep.
The lower reflex arc in the leg is still completely intact, but the brakes are gone. The adult supervision has left the room.
Exactly. Without that descending inhibition, the lower reflex arc becomes hyperreactive. The slightest stretch causes a massive uncoordinated contraction that results in spasticity, rigidity, and hyperreflexia. The muscles are constantly firing because nothing is telling them to stop.
But if you have a lower motor neuron lesion, say a herniated disc crushing a nerve root or a disease like polio, you are physically breaking the reflex arc itself.
Precisely. You've cut the wire going directly to the muscle. The signal never reaches it. Therefore, you get flaccid paralysis, absent reflexes, which we call aphlexia, and eventually, because the muscle isn't being stimulated at all, you get severe denervation atrophy. The muscle simply wastes away.
That makes perfect sense when you visualize the wiring. So, for assessment, early signs of spinal issues often include paresthesia, which is that abnormal tingling or pins and needles sensation.
Right.
And you map this using dermatomes, which are specific areas of skin innervated by a single spinal nerve root.
Mapping dermatomes is a vital nursing skill. It tells you exactly how high up the spinal cord the damage goes. Classic findings, to reiterate. UMN damage equals weakness, spasticity, and hyperreflexia. LMN damage equals flaccidity, atrophy, and hyperreflexia.
But we have to talk about the late, most dangerous findings. If the injury is high in the cervical spine, the immediate threat is respiratory compromise.
Because of the phrenic nerve.
Exactly. The phrenic nerve, which controls the diaphragm, arises from cervical nerve roots C3, C4, and C5. Remember the old medical adage, C3, 4, and 5 keep the diaphragm alive?
Such a classic.
If the cord swells above that level, the patient will stop breathing entirely. Another classic sign of a UMN lesion is an extensor plantar response, also known as a positive Babinski sign in adults.
Right, if you stroke the sole of the foot and the toes fan out and point up, that indicates damage to the descending motor tracts.
For diagnostics on the spinal superhighway, we rely on a few key tools. A myelogram is an X-ray of the spinal cord taken after a radiopaque contrast dye is injected directly into the subarachnoid space. It outlines the cord and shows if a herniated disc or tumor is pinching it.
Yeah, and we also use electromyography, or EMG, where tiny needle electrodes are inserted directly into the muscle to record its electrical activity and differentiate muscle disease from nerve disease.
Looking at the ADPI nursing process for spinal issues, for assessment you must test reflexes symmetrically on a 0 to 5 scale, where 2 is normal. You also check 2-point discrimination. Normal sensation allows a person to distinguish 2 separate points on their fingertips, even when they are only 4 to 5 millimeters apart. The diagnosis is impaired physical mobility and risk for injury. Planning means your priority is preventing skin breakdown because they can't feel the pressure and preventing falls.
This is especially critical in elderly patients who already have naturally diminished proprioception or joint position sense.
Implementation involves meticulously assessing those dermatomes for sensation and myotomes for muscle strength. And evaluation is hoping to see reflexes remain at a normal 2 out of 5, indicating the cord isn't deteriorating.
Priority nursing actions here must be sequenced correctly to prevent a bad outcome. First, assess airway and breathing, especially if the injury is high cervical. You must anticipate intubation before they tire out.
Yeah, don't wait on that.
NED-XT, perform a meticulous dermatome and myotome assessment to map the exact level of the deficit and establish a baseline. Then, you absolutely must check bowel and bladder function, as autonomic disruption is a major red flag for cord compression.
Medications and procedures are heavily intertwined here. Analgesics and sedatives are frequently used before lumbar punctures and EMGs because inserting needles into the spine and up into muscles is painful and anxiety-provoking.
It is. Let's talk about the lumbar puncture procedure itself. It is usually performed at the L3-L4 or L4-L5 subarachnoid space. Why that specific location?
Because the solid spinal cord usually ends around L1 or L2 in adults. Below that, it's just a bundle of nerve roots called the cauda equina, floating in fluid. Inserting a needle there is much less likely to puncture the actual cord.
Correct. Nursing preparation is key here. You place the patient in a lateral, side-lying position with their knees bent tightly to their chest and their chin tucked.
Fetal position, basically.
Yeah, this curves the spine and opens up those intervertebral spaces to allow the needle to pass. But the major post-procedure complication you must watch for is a spinal headache.
This happens because of a CSF leak at the puncture site, right?
Yeah. Yes. When they sit up, the low CSF volume causes the brain to literally sag downward, stretching the pain-sensitive meninges. It is an excruciating headache.
So what do we do about it?
The priority nursing action to prevent and treat this is keeping the patient lying strictly flat for 1 to 2 hours post-procedure. You also need to push oral fluids aggressively to help the body replace the lost CSF. And a practical tip: have them drink through a straw so they don't have to lift their head off the pillow.
That's a great tip. Let's touch on hemodynamics and the autonomic nervous system, which travels through the cord. The sympathetic fibers, located from T1 to L2, use norepinephrine to drive the fight-or-flight response, raising heart rate, shunting blood to muscles.
Right.
The parasympathetic fibers, located high in the brainstem and low in the sacrum at S2, S4, use acetylcholine to rest and digest, slowing the heart, constricting bronchi. And the vagus nerve, cranial nerve X, is the primary driver of this parasympathetic response.
From a fluids, electrolytes, and nutrition perspective, we have to highlight vitamin deficiencies. It's not just physical trauma that damages nerves.
Oh, absolutely not.
Deficiencies in thiamine, which is B1, niacin, pyridoxine, or B6, and cobalamin, which is B12, directly cause nerve demyelination, weakness, peripheral neuropathy, and profound confusion.
B1 deficiency is classic for Wernicke's encephalopathy and severe alcohol use disorder, right?
Exactly. And B12 deficiency is especially common in older adults due to absorption issues.
Right.
It can cause a syndrome called subacute combined degeneration of the spinal cord, which perfectly mimics severe irreversible neurologic decline if you don't catch it and replete the vitamin.
Complications of spinal cord lesions heavily involve bladder dysfunction. The cause is the spinal cord injury disrupting autonomic pathways. The finding depends on the stage. In the early stages, right after a shock to the cord, you might see an atonic autonomous bladder.
It has no tone, so it just fills up.
Right, leading to massive residual volume and overflow incontinence. Later on, particularly with upper motor neuron lesions, you might see a hypertonic bladder with sudden reflex emptying. The nursing action here is frequent assessment of post-void residual volume using a bladder scanner and implementing a strict intermittent catheterization schedule to prevent kidney damage from reflux.
You know the patient with a spinal injury is deteriorating if their CN III deficit levels rise. This means the numbness or loss of sensation is actively moving the dermatomes toward the chest or neck.
Indicating swelling is traveling up the cord toward the respiratory centers.
Exactly. Alternatively, if normal reflexes, which score a 2 out of 5, suddenly become hyperreflexic with sustained clonus, where the foot rhythmically beats when you push it back, scoring a 5 out of 5. That means descending inhibition is being lost.
And escalation. Sudden onset of bowel or bladder incontinence, accompanied by saddle anesthesia numbness in the groin area, is a massive red flag for cauda equina syndrome, where the massive bundle of nerve roots at the base of the spine is acutely compressed.
That is a rapid response and immediate provider notification scenario. It requires emergency neurosurgery to decompress the roots and prevent permanent lower body paralysis and incontinence.
For pattern recognition, if you see weakness, plus spasticity, plus toes pointing up with plantar stimulation, immediately think upper motor neuron lesion.
Let's talk about an ICU pearl and a major exam trap regarding the Romberg test.
Oh, this one is huge.
The Romberg test assesses proprioception. You have the patient stand with their feet together, arms at their sides, and then ask them to close their eyes. If they can balance perfectly fine with their eyes open, but they sway significantly or fall only when they close their eyes, it is a positive Romberg.
Right.
It means they have a posterior column issue in the spinal cord. They've lost their joint position sense and were relying entirely on their vision to stay upright. But what is the major safety trap here?
The safety trap is practically a setup for failure if you aren't careful. You are actively asking a patient with a known or suspected neurologic deficit to stand up and take away their primary balancing mechanism, their vision. You must always be positioned close to the patient with your arms ready, physically prepared to catch them during a Romberg test. If it is positive, they will fall.
Intensivist thinking for spinal pathways. The problem is acute weakness. The failing physiology is motor pathway interruption, either UMN or LMN. The immediate threat is respiratory failure if the lesion is high cervical or high fall risk if lower.
Okay.
The intervention is strict spine precautions, keeping the spine perfectly aligned and getting diagnostic imaging like an MRI. The reassessment is frequent, symmetrical dermatome mapping to ensure the lesion isn't ascending.
If you remember only 5 things about motor pathways from this deep dive. Number 1, the core pathophysiology. Upper motor neurons originate in the brain and cord and act as the brakes, inhibiting lower reflexes. Lower motor neurons directly innervate the muscle to create the reflex arc.
Number 2, your key assessment finding. Spasticity and hyperreflexia mean a UMN lesion. Flaccidity and areflexia mean an LMN lesion.
Number 3, the most dangerous complication is respiratory muscle paralysis from cervical lesions or sudden permanent incontinence from cauda equina syndrome.
Number 4, your priority nursing action is strict bed rest flat for 1 to 2 hours post-lumbar puncture with fluid hydration to prevent a debilitating spinal headache.
And number 5, the most important treatment is a myelogram or MRI to quickly identify the source of cord compression.
The one-sentence clinical picture. A patient with acute ascending weakness, sensory loss, strictly along dermatomes, and changing reflex grades has a spinal cord lesion requiring immediate localization.
If you see flaccid paralysis and absent reflexes, think lower motor neuron injury and do protect the affected limbs from contractures and positioning injury.
We've covered the intracranial pressure dynamics and the spinal cord motor pathways. Now let's bring all of this anatomy, pathophysiology, and assessment together.
Yes, let's do it.
Let's see how an intensivist uses these exact concepts in real time to solve a clinical puzzle and save a life.
Here's where it gets really interesting. We're going to look at the case of JK from the source text. JK is a 57-year-old office manager. She goes to an outpatient clinic complaining of severe persistent headaches that have been bothering her for a few weeks.
Okay.
The provider does a routine neuro exam and finds a very specific visual field deficit she cannot see out of the upper left quadrant of her vision. And then, while still sitting right there in the clinic, she suddenly has a generalized seizure. 911 is called. How does an intensivist instantly reverse engineer this presentation?
Applying our 80-20 overview to this case, new onset seizures and focal neurologic deficits like a highly specific visual field cut in a previously healthy adult are massive, screaming red flags for a structural brain lesion.
Yeah.
This isn't a migraine, this is a mass, likely a tumor, until proven otherwise. By meticulously mapping the exact physical deficit, we can pinpoint the specific lobe of the brain that is affected before the patient ever hits the CT scanner.
So let's break down the pathophysiology of JK's seizure. The trigger is a physical brain mass, likely in the right hemisphere. The physiologic change is that as this mass grows, it physically compresses the optic radiation fibers as they pass through the temporal or parietal lobe on their way to the visual cortex at the back of the brain.
Right.
Regarding compensation, there really isn't any available for this kind of highly focal, localized pressure.
No, the decompensation occurs because that physical pressure causes ischemia, a lack of blood flow, and intense electrical irritability of the adjacent neurons. They become unstable.
Which leads to the clinical findings.
Exactly. The clinical findings are the progressive visual field cut as the fibers are slowly crushed, followed by a sudden chaotic electrical discharge from those irritable neurons, which manifests as the clinical seizure.
The assessment here is classic and builds chronologically. Early on, she had persistent headaches. This is caused either by a generalized increase in intracranial pressure or by the physical mass literally stretching the pain-sensitive duramater.
Yeah.
The classic finding is the visual field defect. We test cranial nerve to 10, the optic nerve, via confrontation, having the patient look straight ahead while bringing a finger in from the periphery of their vision to see when they notice it.
Okay.
The late dangerous finding is the seizure itself. But wait, hold on. I need to clarify something for the listener that always causes confusion. Her vision deficit is on the upper left. But you just said we are looking for a mass on the right side of her brain. How does that work?
It is all about the principle of contralateral processing. The central nervous system loves to cross over. It decussates. The right side of the brain receives visual input from the left visual field of both eyes, and it controls the motor function of the left side of the body.
Okay, I see.
The visual pathways are complex. But essentially, the fibers carrying information from the left side of the visual world travel back, cross the optic chiasm, and end up in the right visual cortex. So a deficit, specifically in the left visual field, tells us instantly that the lesion is interrupting the optic pathways in the right hemisphere of her brain.
Boom. That is exactly how an intensivist localizes the lesion in 3 minutes. For diagnostics, once she's stabilized in the ER, she will need an EEG, an electroencephalogram, to evaluate the electrical seizure activity in the brain and see if she is still having subclinical seizures.
Yeah, it's crucial.
She may also get a PET scan or a SPECT scan. These are fascinating because they don't just look at anatomy, they measure the metabolic activity of the brain tissue.
They are crucial in neuro-oncology. A PET scan can differentiate between a benign, low-metabolism fluid schist, which will show up dark, and a highly metabolic, aggressively growing tumor, which will light up brightly because it is consuming so much energy.
Looking at the ADPI and nursing process for JK's active seizure. For assessment, you must rapidly recognize the seizure activity, time it, and monitor the subsequent post-ictal state of deep confusion and lethargy that follows.
Right.
The diagnosis is a severe risk for ineffective airway clearance during the seizure and altered cerebral tissue perfusion. Planning means your primary goal is that the patient will remain free from physical injury and aspiration during the event.
It's exact.
Implementation. Protect her head, turn her gently onto her side, if possible, to let secretions drain, and absolutely, under no circumstances, insert anything into her mouth.
Yes, that is a persistent myth that needs dying.
Yeah.
Do not put a tongue depressor or your fingers in a seizing patient's mouth. You will break their teeth or lose your finger.
It's just not safe.
Not at all. Evaluation is noting when the seizure naturally ceases and confirming that the patient slowly, safely regains her baseline orientation.
Priority nursing actions during an active seizure must be automatic. First, ensure airway patency and physical safety. Move furniture, pad the bed rails. Next T, once the seizure stops and she is stable and rebreathing, perform a full, meticulous 12 cranial nerve assessment to document any new deficits that might indicate the mass is bleeding or shifting.
Right.
Then, consult the provider to determine if any scheduled anti-seizure medications should be temporarily withheld prior to her EEG.
Why would we hold anti-seizure meds? Because the EEG is designed to capture abnormal electrical waves. If you load the patient up with suppressive medications, you might mask the very abnormal waves you were trying to find to diagnose the seizure focus.
On the topic of medications, JK's history notes she takes lisinopril 10 milligrams daily for hypertension. Her blood pressure in the clinic was 405/80. While that is only mildly elevated, the expert intensivist always keeps a broad differential.
You have to.
You have to rule out a hypertensive crisis as a potential cause of severe headaches and seizures, though it's less likely with those specific numbers. Also, before she gets that EEG or PET scan, the nurse must ensure that any tranquilizers, sedatives, or CNS depressants are held.
Absolutely, because those drugs fundamentally alter the brain's baseline electrical and metabolic activity, rendering the tests completely useless.
Let's talk about a major diagnostic procedure she might face if imaging shows a mass. Cerebral angiography. This is used to visualize the intricate vascular supply of the brain. They might be looking for an aneurysm, or they might be trying to see exactly what blood vessels are feeding this suspected tumor before a surgeon tries to cut it out.
Nursing preparation and post-care for cerebral angiography is intense. A catheter is usually inserted into the large femoral artery in the groin and threaded all the way up through the aorta into the neck.
Okay.
Before the procedure, you must assess the patient's baseline neurostatus meticulously, because the primary risk of angiography is that the catheter can scrape the side of an artery and dislodge a thrombus, causing a massive stroke.
That's a huge risk.
It is. You also need to warn the patient that when the contrast dye is injected, they will feel a sudden, intense, warm flush radiating through their head and body. It's normal, but it feels terrifying if you aren't expecting it.
And what about after the procedure?
Post-procedure, the absolute priority is maintaining strict bed rest for 4 to 6 hours, keeping that affected leg perfectly straight, and continuously monitoring the femoral artery puncture site for bleeding or a hard, expanded hematoma, while frequently checking the distal pulses in the foot to ensure blood flow isn't compromised.
Let's look at the hemodynamics and respiratory demands of a seizure. This is critical. During an active seizure, the brain's metabolic demand for oxygen skyrockets and needs massive amounts of energy to sustain that electrical storm.
Yeah.
But simultaneously, the patient's ability to breathe and deliver that oxygen is often compromised by the violent muscle contractions of the chest wall.
You must monitor respiratory rate and protect the airway. And anatomically, remember that the glossopharyngeal and vagus nerves, cranial nerves IX and X, control the gag and swallow reflexes.
Right.
If the brain is electrically short-circuiting during a seizure, those protective reflexes might be completely absent. This creates a massive aspiration risk if they vomit or have excessive secretions. That is why turning them on their side is so vital.
Regarding fluids and electrolytes for this case, while not explicitly problematic in her initial labs, it is vital to understand how that peaky scan works. A P-scan specifically measures glucose metabolism. The brain runs exclusively on glucose. It can't use fat or protein for energy directly.
Oh, only glucose.
Highly active tumor cells consume massive, disproportionate amounts of glucose to fuel their rapid growth. The radioactive tracer they inject for the PE scan is essentially a glowing sugar molecule. The tumor eats it up, which is how the scan lights those cancer cells up as bright, terrifying spots against the background of normal tissue.
Now let's talk about complications, specifically from a right parietal lesion, which is where her visual deficit points us. The cause is the right parietal mass. The finding can be a bizarre, fascinating phenomenon called anosognosia.
I've read about this. It's a complete lack of insight, right?
It's deeper than just denial. Anosognosia is a profound neurological inability to recognize one's own bodily defect or disease. The parietal lobe helps map our body in space. If the right parietal lobe is damaged, the patient might be completely paralyzed on their left side, but their brain fundamentally cannot process that fact. They will completely deny that anything is wrong. They might say the paralyzed arm belongs to someone else.
That is wild.
The priority nursing action here is intense safety measures. You must protect the patient from injury because they will try to stand up and walk, genuinely believing their left leg works perfectly, and they will inevitably fall due to profound neglect of their left side.
You know JK is deteriorating if the seizure does not stop after a few minutes, or if she has back-to-back seizures without waking up. That is progressing into status epilepticus, which is a life-threatening medical emergency that rapidly causes permanent brain damage due to hypoxia and metabolic exhaustion.
Exactly.
Alternatively, if she wakes up but suddenly develops aphasia and inability to comprehend or express language, it indicates the lesion or the surrounding swelling is expanding into Wernicke's or Broca's areas, which are typically located in the left dominant hemisphere.
Escalation in this specific scenario. An active, new-onset seizure in an outpatient clinic is a call 911 immediate code situation. It is an airway emergency first and a neurologic emergency second.
pattern recognition for JK's presentation. If you see a new onset headache plus a focal localized deficit like a visual cut plus a seizure, you must think expanding brain mass or vascular malformation.
And there is an incredible ICU pearl from the text that novice nurses frequently miss regarding cranial nerve testing. Assessing cranial nerves isn't just about making the patient smile or stick their tongue out.
Right.
Take cranial nerve 8, the vestibulocochlear nerve. It involves both hearing and equilibrium. The text explicitly notes that JK denies any dizziness or vertigo. This is a crucial negative finding. It helps the intensivist confidently rule out a primary brainstem or cerebellar issue, keeping the diagnostic focus squarely on the cerebral hemispheres.
Intensivist thinking for JK's case. The problem is a new onset seizure in the clinic. The failing physiology is cortical electrical irritability caused by physical compression from an expanding mass. The immediate threat is hypoxia and aspiration during the active seizure. The intervention is strict airway protection, physical safety, and abortive seizure meds if it continues. The reassessment is a meticulous post-ictal neurologic exam focusing heavily on cranial nerve 2 and charting those visual fields.
If you remember only 5 things about localizing acute lesions from this case, number 1, the core pathophysiology. Focal masses compress specific anatomical pathways, like the optic tracts, creating highly specific physical deficits before causing generalized electrical irritability and seizures.
Number 2, your key assessment finding. Contralateral visual field deficits. A left field cut means a right brain lesion.
Number 3, the most dangerous complication is aspiration during a seizure due to the temporary loss of cranial nerves IX and X function, followed by status epilepticus.
Number 4, your priority nursing action is airway and physical safety during the seizure, and remembering to hold sedatives before an EEG.
And number 5, the most important treatment is angiography or MRI to precisely map the blood supply and location of the lesion for surgical or medical intervention.
The one-sentence clinical picture. A 57-year-old female presents with a new focal visual deficit and secondary seizures, a presentation highly suspicious for an expanding right hemisphere mass.
If you see a new onset focal deficit followed by a seizure, think structural brain lesion and do prioritize airway safety and rapid imaging.
So what does this all mean? We have covered a massive amount of ground today.
We really have.
We started deep inside the rigid bank safe of the skull, tracing the lethal mechanics of intracranial pressure and exactly why that cranial nerve of third people blows. We traveled down the spinal superhighway, deciphering the physiological difference between the hyperreactive spasticity of upper motor neuron damage and the dead flaccidity of lower motor neuron damage.
Right.
And we brought it all together with JK, proving that a thorough, targeted neurologic assessment is essentially the most powerful diagnostic imaging tool you have before the patient ever leaves the room for a CT scan.
It is the ultimate tool. And before we end, I want to leave you with a truly mind-bending fact from the text to mull over. For decades, the absolute dogma in medical science, what every student was taught, was that central nervous system neurons were strictly non-mitotic.
Right, that they couldn't divide.
The firm belief was that once you lost brain cells to a stroke, trauma, or a tumor, they were gone forever. The brain could not regenerate. But the textbook on neurorecovery is actively being rewritten as we speak. Recent research shows that a specific subset of glial cells called astrocytes actually proliferate after CNS injury. And neurogenesis, the literal birth of brand new neurons, may occur from stem cells hidden deep within the brain.
That is incredible.
It is. The brain has an inherent dormant capacity to heal itself that we're only just beginning to uncover and understand.
That is an incredibly hopeful thought to end on. The brain is not just a rigid, static machine. It is a dynamic, adaptable, and profoundly resilient system. Thank you for diving into the complex, murky waters of neurocritical care with us today. Take this 80-20 intensivist mindset. Remember that the bedside assessment of the patient is always your highest priority, and aggressively apply it on your next shift. We will see you on the next deep dive.